everyone. Fungal keratitis has been a leading cause of monocular blindness worldwide. We all come across many patients of fungal keratitis routinely in our OPD. Despite aggressive systemic and topical antifungals, results were not satisfactory in the patients. One of the major causes of poor healing in these patients were poor penetration of antifungals. Although voriconazole penetrates corneal layers better than netamycin, as it was mentioned by ma'am in previous presentation, still there are times when the treatment failed. The rate of corneal perforation and melting are so high in these patients that there was a need for an alternative route of administration. And then came the route through intrastromal and intracameral antifungal injections. Weeks after weeks, healing, if occurred in patients, it was almost always associated with scarring. Also, such a long duration of treatment made affordability another hindrance for the patient. So my topic today is comparison between intrastromal injection of voriconazole and amphotericin B in deep and recalcitrant fungal keratitis. A prospective randomized and comparative study was performed on eyes with deeper or resistant fungal keratitis. Eyes were randomly allocated into two groups according to their order of presentations. Group A included eyes treated with intrastromal injections of voriconazole, 50 microns in 0.1 ml, and topical eye drops of voriconazole 1% and 5% netamycin was given along with it. Yeah. In Group B, intrastromal injection of amphotericin B 25 micron in 0.1 ml was given along with topical 1% voriconazole and 5% netamycin. Healing of fungal keratitis was considered as the primary outcome measure. Amphotericin B has broad spectrum of activity. It is effective against most of the antifungals including Candida, Aspergillus, Penicillium, and to a lesser extent against Fusarium. It should be stored in dark and refrigerated places in 2 to 8 degrees centigrade. Dose of intrastromal injection was 25 micron per 0.1 ml. Mechanism of action is it creates a pore in the ergosterol, causing extravasation of all the monovalent ions and leading to fungal cell death. Voriconazole, on the other hand, it was effective against Candida, Aspergillus, as well as Fusarium and other fungus. More effective than first generation of triazoles. Also, its greater stability was advantage over other polines. Voriconazole inhibits demethylation of lanosterol and does not let ergosterol to be formed. The technique of intrastromal injection was we took 30 gauge needle and intrastromal it was given at the interface between the clear cornea and where the stromal infiltration was there. 0.1 ml was injected at 5 different sites. So we found that voriconazole had greater effectivity and there was significant reduction in the size of ulcer in 4 weeks. To conclude, the complete healing of fungal keratitis was higher in Group A than in Group B. The difference was statistically significant. Duration of healing was 2 to 4 weeks in Group A and 2 to 6 weeks in Group B. Lab studies showed increased prevalence of filamentous fungi, but the difference between the two groups was statistically non-significant. So, voriconazole intrastromal injection was better than intrastromal amphotericin B injection. Thank you.
Have you used any addition eye drops in apart from injections?
So, topical 1% voriconazole and 5% netamycin was given to all the patients.
All the patients.
Yes, sir.
Fine, nice. Thank you.
Thank you, sir.